Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is surgical management of pelvic organ prolapse, the apical support repair. As you know, goals of prolapse surgery are mainly to resolve or reduce the POP-induced symptoms, pelvic organ prolapse-induced symptoms, by restoring the bladder, bowel, and coital function, and also to restore the normal anatomy and treat SUIs, that is stress urinary incontinence, if needed in the same sitting. So many surgeries we do for the pelvic organ prolapse, such as anterior colpoplasty for cystocele, posterior colpoplasty with or without perineoplasty for posterior compartment defect, apical support surgery, enterocele if it is there, then enterocele repair. Then procedures include either removal of uterus, that is hysterectomy, or hysteropexy, that is uterine conserving surgery. Colposcleosis is obliterative surgery where vaginal obliteration is done, and the procedures can be either done as vaginal approach, abdominal approach, or laparoscopically. And in the last few years, even robotic surgeries also are being tried. Now, this is in short about the pelvic floor and delancey supports. The details about this are we have already seen in the previous class on the supports of the pelvic organs. Delancey supports are level 1, level 2, level 3. Level 1 by uterosacral and cardinal ligament complex, level 2 by arcus tendinous fascia pelvis, and level 3 by perineal body and perineal membrane. Perineal membrane along with pelvic diaphragm forms the pelvic floor. Pelvic diaphragm is nothing but the levator muscle with superior and inferior fascia, and this pelvic floor along with these delancey supports are the main supports of the pelvic organs. Now some important terminologies for today's class which we should remember. Colpoplasty is repair of cul-de-sac or enterocele prevention or repair. So pouch of Douglas repair is the colpoplasty. Colpopexy is anchoring the vagina. Colpos is the term used whenever we are describing vagina. That way you remember colpopexy is anchoring the vagina to a fixed structure after doing hysterectomy. Whereas hysteropexy is anchoring cervix and vagina to a fixed structure with uterine preservation surgery. If the terminology which is used is sacrocolpopexy, what does it mean is anchoring vagina to sacral promontory, which is usually done as an abdominal procedure. On the other hand, sacrospinous colpopexy or fixation is anchoring wall to sacrospinous ligament, which is usually done as a vaginal procedure after doing hysterectomy. So that is the difference in these two terminologies. That is why I have included these one after the other. Sacrocolpopexy is to the sacrum. Sacrospinous is to sacrospinous ligament. Partial trachelectomy is excision of part of the cervix whenever there is a cervical elongation in a patient of prolapse. Vault is the terminology used for the vagina after doing the hysterectomy. Native tissue repair is where mesh or any synthetic material is not being used. This is the POPQ grid we have already seen in the last class, and this is a revision. Point AABA are telling us about the anterior compartment, C and D about apical, and point AP and BP are telling us about the posterior compartment defect. Now, what is the definition of in today's class? Mainly, we will be focusing on apical compartment repair or the apical repair of the apical compartment defects. So, what is the definition of apical compartment defect? Is when the point C. C is the lowermost point of the cervix or of the vault in a case of post-hysterectomy patient, where point C is normally it should be minus total vaginal length minus 2 centimeters. Anytime C is below this level, then apical prolapse is present. Now one example is if total vaginal length is 10 centimeters and point C is at minus 6, that indicates that apical prolapse is present. And if apical suspension is not done, now this patient suppose has a large cystocele and we only do the anterior colporaphy and we fail to do the apical compartment defect repair, then if it is not done, there are high chances that this patient will have a recurrence of pelvic organ prolapse. Now, this importance of apical support surgery has been mainly identified in the last few years. Now, most common compartment defect, if you are asked, is the anterior compartment defects. In other words, cystocele, urethroceles, cystourethroceles are commonest presentation in a case of pelvic organ prolapse. But in 50% of anterior compartment defects, these have apical support defect also, which is associated with that. And we need to diagnose it and correct it. If only cystocele repair is done in these cases, then reprolapse rate is or recurrence rate is as high as 20%. Apical support procedure is to be added to prevent recurrence. What are the apical support surgeries? We can divide it into vaginal and abdominal. Vaginally, we have three main. First is Mackal's colpoplasty, second is uterosacral suspension, and third is sacrospinous ligament fixation. Iliococcygeal suspension, though described, is less possible because there is a possibility that it can lead to vaginal shortening. Abdominal procedure is abdominal sacropexy, which is considered as a gold standard procedure, abdominal procedure for the apical support surgery. Now, various anchoring points for the apical support surgeries are: where do we anchor the descended vagina or the uterus with the cervixes, either to sacral promontory in abdominal sacrocolpopexy or to sacrospinous ligament, which is also called as coccygeal sacrospinous ligament complex or CSSL, as coccygeal muscle along with sacrospinous ligament forms the CSSL complex, or to the uterosacral ligament. So this is the vault, and if you fix it to the uterosacral ligament, that will be uterosacral ligament suspension. Now, hysterectomy versus hysteropexy. Hysteropexy has some advantages over hysterectomy, such as less blood loss, less operative time, rapid recovery, and no risk of premature menopause. Disadvantages are there, such as strict selection criteria is needed because future hysterectomy is technically difficult once we do the hysteropexy. It is not a good procedure for high-risk group for genital cancers such as endometrial, ovarian, or cervical cancer. It should not be done if there is cervical intraepithelial neoplasia is there or abnormal uterine bleeding is already patient is having that. Cervical elongation, if it is there with POP, it needs hysterectomy or at least partial trachelectomy. For this reason, because of these disadvantages of hysteropexy, fertility preservation is whenever it is desired by the patient, pastry trial is advised first. And if there is a failure of the pastry trial, then only we should go for hysteropexy. Now coming to the first procedure, that is Mackal's colpoplasty. It provides apical suspension, it leads to enteroceal repair, and it prevents the recurrence of pelvic organ prolapse. It is the most popular technique of apical support whenever vaginal hysterectomy with anterior and posterior repair is done in a patient of pelvic organ prolapse. Procedure is 3 or more internal non-absorbable sutures are taken which are passing through uterosacral ligament on one side, peritoneum of the pouch of Douglas or cul-de-sac in the center, and then going through the opposite uterosacral ligaments. At least one external delayed absorbable suture is taken, which passes through posterior vaginal mucosal margin edge or posterior vagina, uterosacral ligament on one side, peritoneum in the center, which is higher to the internal sutures, and it emerges from opposite sided uterosacral back to the posterior vagina. First, internal sutures are tied, then wart closure is done, and in the end, external suture is tied. Now, to explain diagrammatically, when we do the vaginal hysterectomy for a case of prolapse, then this is the picture which we get at the end. This is the anterior vaginal margin. This is the posterior vaginal margin. These are the pedicles of uterosacral ligaments going like that, and this is the pedicle of uterosacral ligament. And in between these uterosacral ligaments, we can see the peritoneum, which is at the covering the pouch of Douglas, or which is covering the cul-de-sac. And if this is lax or elongated, that indicates that enterocoel is already present, and we need to excise the excess peritoneum here. And if posterior vagina also is excessively elongated, that posterior vagina also needs to be shortened if it is too lax. So as we can see here, there are three internal sutures which are taken with the non-absorbable or suture material, because these are internal, these are not piercing the vagina. Non-absorbable sutures are preferred, and these are taken, the suture is passing through uterosacral ligament on one side, then one or two bites through the peritoneum of the pouch of Douglas is taken, and then the suture emerges through the opposite sided uterosacral ligament. Proximal suture is taken first, and then traction is given over it, and then the next suture is given, and then traction over the second one, and the third is taken. Minimum 3 sutures of the internal sutures are advised by as per the Schulz technique of Mackel's colpoplasty. External suture is passing through the both anterior and posterior vaginal margins, and it is called as external because when we do speculum examination post-operatively, it will be seen. That is why it is external, and as it is present in the vagina, it is taken with a delayed absorbable suture material, because with the non-absorbable, there is a possibility of having a development of granulation tissue or dyspareunia, and that is why delayed absorbable suture is preferred. It passes through both the vaginal margins, anterior and posterior, then through the uterosacral ligament higher to the internal sutures. Even peritoneal bites are also at a level higher to the internal sutures, and then it passes through the opposite sided uterosacral ligament, and then coming back to posterior vaginal margin and anterior vaginal margin. And when it will be tied, it will be tied at the front of the anterior vaginal wall. So this is important to remember. Minimum 3 internal sutures and minimum 1 external suture is taken in Mackel's colpoplasty. What is happening is, as we can see here, there is a plication of uterosacral ligaments. Uterosacral ligaments are shortened because these are brought to the midline because of the tie. When we tie these internal sutures, as well as when we after closing the vagina, when we tie the external suture, that also brings the vagina at a higher position, that leads to apical support, with the vagina being anchored to both the uterosacral ligaments, and uterosacral ligaments are ultimately brought towards the midline, and that is how the lax uterosacral ligaments with a laxity going laterally, that is being taken care of by this Mackel's colpoplasty. Excision of excess posterior vagina and pouch of Douglas peritoneum to be done if it is, but one has to take a care not to excise too much of vagina, as otherwise it will lead to shortening of vagina. Plication of uterosacral ligaments at center is achieved by this Apical colpoplasty, and that leads to the vault support, apical support. Enteroceal repair is achieved by this procedure, and what is more important is nowadays, even if there is no enteroceal, prevention of enteroceal is achieved when we do this colpoplasty. And nowadays, whenever vaginal hysterectomy is done for prolapse and anterior and posterior repair as needed is done, always some procedure to do the provide support to the apex is always added, so that to prevent the recurrence of pelvic organ prolapse, and one of the procedure is this Mackel's colpoplasty. Outcome is satisfaction rate is 80%. That means symptom relief is in majority of the women. Ureteral obstruction can be seen in, but it is seen in less than 3%. But that is the reason cystoscopy should be done at the end of the procedure to rule out ureteric obstruction. Dyspareunia, because of the placement of uterosacral ligaments at the center, is seen in 20% of women, and need of reoperation is seen in 5%. That means for the repeat surgery, the chances of having a repeat pelvic organ prolapse are less when we do this Mackel's colpoplasty. Second procedure is uterosacral ligament suspension. Now, the difference between Mackel's and this uterosacral ligament suspension is there is no midline plication or folding by taking sutures through the pouch of Douglas peritoneum in uterosacral ligament suspension. So, as in Mackel's, we have seen the suture is passing through one uterosacral, then it passes through the peritoneum and then to the opposite uterosacral. That is not so in uterosacral ligament suspension. Vaginal apex is anchored to ipsilateral intraperitoneal part of uterosacral ligament. So it is an intraperitoneal procedure. It is done at or below the level of ischial spines to avoid ureteric injury or kinking. If the uterosacral ligament stitch is taken above the level of ischial spines, chances of kinking or injury to the ureter are very high. Absorbable suture, delayed absorbable suture passes through anterior vaginal wall, uterosacral ligament, and it comes back through posterior vaginal wall. Sutures are tied, which also closes the vagina. Cystoscopy is mandatory at the end of the procedure to rule out ureteric kinking or injury. So as this diagram, you will be able to understand what is being done. So first the sutures are taken through uterosacral ligaments. Then needle is passed through the one end and the suture is passed through anterior vaginal margin. Other end is passed through posterior vaginal margin. So same suture, first you take the suture through uterosacral ligaments and then pass these sutures, one end through anterior and other end through posterior vagina, and when we tie it, that leads to closure of the vagina also. 3 sutures are usually taken on each side with a distance of 1 centimeter in between. This is the level of ischial spine, and as I said, the suture should pass at or below the level of ischial spine. It should not be above the level of ischial spines, so that there should not be any injury to the ureters. We have to pull the uterosacral ligaments medially and then take the suture to avoid injury to the ureters. Satisfaction is high with uterosacral also. Ureteric obstruction is a main complication seen in 5%. That is why cystoscopy is mandatory. Patients do have buttock or perineal pain in around 6% of the patients, because the just by the side of the these uterosacral ligaments, sacral nerves are passing, especially S4, fourth sacral nerve. And that is the reason why some patients have the entrapment of this nerve, and that leads to buttock or perineal pain or lower extremity pain. And need of reoperation is seen in around 5% because of the recurrence of prolapse or because of the severe complications. Uterosacral we have seen already. Now uterosacral suspension, where we are suspending the vagina with the uterosacral ligament after doing hysterectomy. Now hysteropexy is where we conserve the uterus and attach the intact uterus to the uterosacral ligament. It can be done vaginally by doing a posterior colpotomy, that is giving the incision over the posterior fornix, and delayed absorbable sutures are passed through uterosacral ligaments and through the cervix, posterior vagina, and colpostomy incision also. So it anchors the cervix and vagina with the uterosacral ligament. Both are getting lifted up, providing the apical support where patient wants uterine conservation. Third procedure is sacrospinous ligament fixation. It is also called as coccygeus sacrospinous ligament complex. Sacrospinous ligament is also called as CSSL, as a coccygeus muscle and sacrospinous ligament together are forming a complex. It is usually done on one side only, so right side it is commonly done. Medial and lateral third of the ligament should be avoided. The suture should pass through the middle one third, not medial and not lateral one third. Superior margin of the ligament needs to be avoided. Procedure related complications are recurrence of pelvic organ prolapse in 20%, buttock pain in 10%, rectal injury can occur, and rarely there can be a life threatening vessel injury also. So some complications are serious with this procedure. As you can see here, this is the sacrospinous ligament running from ischial spines to the sacrum. And what we need to avoid is avoid the superior margin, because these vessels are pudendal vessels are running along the superior margin. We need to avoid the uh, medial third also, because the sacral nerves are present here at the medial one third of the sacrospinous ligament. Lateral one third also needs to be avoided, because here the pudendal vessels are present. And that is the reason best site to take a suture is middle third of ligament. One or two sutures are taken anchoring the vault. That is, after hysterectomy, vaginal cup is anchored so that there is a apical support provided by this suture. One or two sutures are going through the sacrospinous ligament, middle third of sacrospinous ligament, and it should not be reaching to the superior margin of the ligament. That we need to remember. Sacrospinous hysteropexy can also be done where uterine conservation is desired by the patient, where what is done is fixation of uterosacral ligaments on both sides to the sacrospinous ligament on right side. And it is done vaginally. Partial trachelectomy is done if there is a presence of cervical elongation along with this procedure. Now, use of mesh, vaginal mesh, colpopexy or hysteropexy. 8% mesh-related complications requiring repeat surgery are observed whenever mesh is used. So it is considered as a high-risk surgery at present. And only one procedure where the successful use of mesh is at present is being used is in a abdominal sacrocolpopexy, where mesh is anchored to sacrum. Because of this complication, it is a less popular procedure. Mesh complications are more with colpopexy as compared to hysteropexy. Vaginal mesh hysteropexy is preferred, that is why, over the colpopexy. Mesh center at anterior cervix, and mesh center of the mesh is anchored to anterior cervix, and both ends are attached to sacrospinous ligament. That is what is done in hysteropexy. Anchoring the cervix with the both-sided sacrospinous ligaments. Coming to abdominal sacropexy, ASC, it is anchoring vagina to anterior sacral ligament by using either a native or biological tissue or synthetic material. It provides apical support. It is considered gold standard procedure at present. It prevents as well as it treats recurrent pelvic organ prolapse. It is the procedure of choice for wall prolapse. Wall prolapse is prolapse after hysterectomy. Procedure it can be done laparoscopically or by doing laparotomy. Usually financial incision is preferred. Pre-sacral dissection to expose the anterior sacral ligament is the first step usually, and that is to be done carefully as vessels are running, middle sacral vessels are running there, and we need to be careful while doing this dissection not to injure. We have to identify aortic bifurcation, right common iliac vein and right ureter, and then only we should be dissecting this pre-sacral space to avoid injury to all these important structures. Care to be taken not to injure the middle sacral vessels as the vessel retracts and if there is a hemorrhage, hemostasis is difficult and severe hemorrhage also can occur. Life-threatening hemorrhages are also reported with that. And hysterectomy is done. Then after doing hysterectomy, we have to create rectovaginal and vesicovaginal plane by packing the vagina so that we separate the rectum from the vagina, we separate the bladder from the vagina so that we can attach the mesh on anterior and posterior surface of the vagina forming a Y. Other end of the mesh is to be attached. So the two ends, we cut the mesh and we need two ends of the mesh, two long strips. One strip is attached to anterior vagina, other to the posterior, and then we suture this with each other over the apex of vagina so that it forms a structure like a Y. Other end of this mesh is sutured to anterior sacral ligament, and we can pass this mesh retroperitoneally. If it is passed intraperitoneally, then to avoid small bowel obstruction in future, what is to be done is a abdominal Halban colpoplasty. Cystoscopy again to be done at the end to mainly confirm that there is no ureteric injury. So this is how the mesh is anchored over the anterior and posterior vagina. Two strips are anchored and then these are sutured together, and so it forms a Y-like structure, and it should not be taut, it should be loosely present over the sacral surface, and it is anchored to the anterior sacral ligament by taking care not to injure the middle sacral vessels. Complications of sacrocolpopexy are bowel injury, intestinal obstruction can occur, ureteric injury can occur, hemorrhage can be there, which can be life-threatening with a sacral vessel injury, and a long-standing complication after a few months is mesh exposure, or what is called as mesh erosion in the vagina, leading to discharge, dyspareunia, or pelvic pain. But presently, this is the gold standard for wall prolapse, this abdominal sacrocolpopexy, and it is preferred in high-risk women who have a high-risk factor or who are at high risk for recurrence of pelvic organ prolapse. Now, sacrohysteropexy, as the name suggests, uterine conservation is desirable. Then what is done is the same way. The mesh is applied to the cervix anteriorly and posteriorly, cervicovaginal junction, and then it is passed through broad ligament and it goes retroperitoneally to the sacrum. Mesh erosion is less common with sacrohysteropexy as compared to sacrocolpopexy, but presently less studies are available. Another this modification is sacrocolpoperineopexy, where there is a level 3 support defect. That is, there is a defect at perineal body or perineal membrane, and patient has difficulty in defecation and splinting is needed. Then in these cases, along with the vagina, even perineal body is also anchored to the one end of the this mesh, and other end is anchored to the sacral anterior sacral ligament. So to summarize, apical defect repair is nowadays considered most important identification as well as repair whenever there is a pelvic organ prolapse. It reduces the risk of recurrence of pelvic organ prolapse. It can be done as colpopexy, where hysterectomy is done and then we anchor the vagina with the various fixed points, or it can be done as a hysteropexy, where uterine conservation is done. In the colpopexy, it can be done vaginally or abdominally. Abdominal, there is only one procedure, abdominal sacrocolpopexy. Vaginally, we have three procedures, Metcalfe's colpoplasty, which is the most popular, and I have done in majority of procedures I have performed operated on pelvic organ prolapse. What I have done is a Metcalfe's colpoplasty. Now, high uterosacral suspension can also be done, and sacrospinous fixation can be done. So for uterosacral, the word which is used is suspension. Just remember, there is sacrospinous ligament fixation, it is called as. Hysteropexy can be done vaginally or abdominally. Abdominal is where it is done as a sacrohysteropexy, where this cervix and vagina is anchored with the sacrum. Vaginally also hysteropexy can be done by two procedures, either by sacrospinous fixation or by uterosacral suspension. So that is how with this diagram you can remember the various main procedures done for the apical defect repair in a case of pelvic organ prolapse. Now these few things which you must remember along with these procedures which are most important are Metcalfe's colpoplasty is comparatively safer as compared to other ways too. Here, uterosacral suspension is associated with a ureteric injury as a main complication. Sacrospinous fixation is associated with more possibility of a buttock pain or lower extremity pain. Abdominal sacrocolpopexy, though considered as gold standard, it has a risk of mesh erosion or mesh exposure and as a long-term and immediate complication of hemorrhage, which can sometimes be life-threatening also. Mesh repair is at present for all these procedures. There is a question mark because there is a possibility of a mesh erosion, and that is why it is not popular except for abdominal sacrocolpopexy. For hysteropexy, there is uh, limited place in the case of apical defect repair because hysteropexy once we do and patient needs a hysterectomy later on, technically that hysterectomy becomes more difficult and selection of the patient is very important, is limited. That is most important is to select the patient for hysteropexy carefully. It can be done vaginally or abdominally with the same complications as for the colpopexy. Now, this is most important slide. How to decide? So many procedures we have seen only for apical defect repair. So which procedure is better for which patient? It depends on what are the patient's goal. When we take history of the patient, when we decide to operate, we need to do counseling of the patient and understand what are the patient's goal. What patient, which symptoms she wants relief from which symptoms, whether she wants uterine preservation or not, whether she is ready mentally for a repeat surgery in future. All these are to be taken into consideration. Most important point is surgeon's expertise. So we should not be trying too heroically, too risky surgeries by exposing the patient to unnecessary risk. So surgeon's expertise plays an important role in choice of surgery, and it has to be a shared decision by discussing all the options with the woman, with the patient and the relatives, by weighing risk and benefits of various procedures. So to summarize, for summary of apical repair surgeries, delayed absorbable sutures are preferred over non-absorbable because these non-absorbable sutures can lead to dyspareunia. That is why vaginal apical repair procedures, usually the sutures which are used are delayed absorbable. Results of Metcalfe's colpoplasty, uterosacral suspension, and sacrospinous fixation are comparable, almost same. Urinary complications are more with uterosacral suspension. Buttock pain because of nerve injuries is more commonly seen with sacrospinous fixation. Mesh vaginal hysteropexy is safer than colpopexy. Abdominal sacrocolpopexy provides better results than all these vaginal procedures, and that is why it is considered at present as gold standard, which can also be done laparoscopically. Chances of recurrence of prolapse are minimum with this. Choice of surgery depends on patient's goal and surgeon's expertise. Thank you so much. And I have prepared this mainly on the basis of T-Lens operating gynecology. Thank you once again.